Hello everyone, my name is Gabor Toth. Thank you for tuning in today to learn more about radial access for neurointerventional procedures. Transradial access, TRA, or simply radial access, was initially mostly used for cardiac interventions. Earlier studies demonstrated increased safety and equal effectiveness compared to transfemoral access, or TFA. Over the last few years, radial access has been increasingly used for neurointerventional procedures, reportedly due to lower complication rates, shorter hospital stays, and patients not needing to lay flat after the procedure for several hours. While transradial access can be an excellent access tool, it may not be favorable for certain anatomic variants. Radial access has several versions, including standard right transradial access, distal right transradial access, or snuffbox access, and left transradial access. In order to perform transradial access efficiently and safely, we have to understand the vascular anatomy of the arm and the forearm. The gross anatomy is depicted on the picture. The main arteries of the arm include the brachial artery, possibly a brachioradial artery, radial artery, ulnar artery, recurrent radial artery, recurrent ulnar artery, and a common interosseous artery. A normal anatomic variation is seen on the left side of the figure with a brachial artery dividing into radial and ulnar arteries. However, vascular anomalies can be seen in up to 14% of the population. One of the most frequently seen variants is present in about 10%, in which case a brachioradial or high origin radial artery is seen. Certain variations with the presence of this brachioradial variant are seen on the rest of the images on the screen. The variant brachioradial artery may be hypoplastic or normal in size and could be connected to or separate from the radial artery. The presence of this variant increases the risk of vascular complications during radial access. A less common variant involves a larger common interosseous artery, which rarely can be mixed up for the radial artery, and placement of a sheath or a catheter can result in severe spasm or retained catheter in the vessel, even sometimes requiring surgical removal in rare cases. Radial loop, which is present in approximately 1% of the population, either in the main radial artery or at the level of the recurrent radial artery, can prevent successful radial access and may pose a potential for vascular injury. If we follow the radial artery distally to the hand, we can identify branches including the previously mentioned recurrent radial artery higher up at the elbow, the palmar carpal branch, the superficial palmar branch, the deep palmar branch, the arteria princeps pollicis, and the arteria radialis indicis. These branches provide supply to the hand, thumb, and index finger, respectively. The radial artery runs superior to the anterior surface of the distal end of the radius, which is very important because it is an easy compression site for hemostasis at the end of the procedure. The artery continues between the long and short extensor of the thumb in the anatomic snuff box, which is used for distal radial access. The radial artery size ranges usually between approximately 1.1 and 3.9 millimeters. In order to prepare for a radial access procedure, it is essential to perform a history and physical examination that includes medications, anticoagulation, dual antiplatelet therapy, prior angiograms that were evaluated for unusual anatomy or history of radial artery spasm or other complications in the past. Most of the diagnostic radial access cases are performed under conscious sedation or local anesthesia, but neurointerventions usually require MAC or general anesthesia. It helps to use a topical anesthetic on the skin at the radial puncture site approximately 30 minutes before puncture, because this may increase patient comfort and may reduce the risk of vasospasm. Pre-procedure evaluation of the collateral circulation with Allen and Barbeau tests is no longer considered necessary due to lack of clinical relevance. For regular transradial access, usually the hand is in supine position whereas a more neutral position with the wrist in mild ulnar deviation is required for distal transradial access. Pulse oximetry is usually placed on the hand to monitor for hypoxia. The patient's arm is usually stabilized next to the patient's body on the right side or across the abdomen for left-sided radial access cases. Ultrasound is highly recommended for better visualization and safe access. Femoral access instead of radial access should be considered if the vessel size is under 2 millimeters. Ultimately, multiple factors play a part in the decision about utilizing radial access for a procedure. Arch anatomy, anatomic variations, for example, an aberrant subclavian artery, bovine arch, inverted arch, or steep vascular angles, increased vessel tortuosity can make radial access challenging. A prior angiogram or CT angiogram can be helpful to better plan vascular access and procedural steps. In particular, access to the left and right vertebral arteries may be more favorable from their respective radial arteries, whereas the left common carotid angle may be sometimes easier from either transradial or transfemoral access. The size of the sheets or catheters used for a certain procedure are usually determined by the radial artery size on ultrasound and the diagnostic or interventional nature of the procedure requiring different size devices. As mentioned earlier, the patient's antithrombotic regimen, single or dual antiplatelet therapy or anticoagulation has to be taken into account. For successful radial artery access, the radial styloid process is usually palpated at the wrist first. The access point is usually just proximal to this landmark. At this location, the radial artery is easily compressible and usually larger in caliber. A linear high-frequency ultrasound transducer provides adequate spatial resolution to follow the needle's path into the artery. In cases of distal snuffbox transradial access, the artery is more superficial to the skin. A smaller ultrasound transducer is usually better for adequate spatial resolution to avoid the cephalic vein and the superficial branches of the radial nerve. The scaphoid and the trapezium bones are also visualized and represent a deep border for the access point. Snuffbox radial access allows puncture of the vessels distal to the origin of the superficial palmar arch, therefore reducing the risk of hand ischemia. Due to the relatively small size of the radial artery, thrombosis and spasm can occur. A specific radial cocktail or mix is favored to avoid these complications. It usually contains a blood thinner such as heparin, a calcium channel blocker, for example verapamil, and a nitrate such as nitroglycerin. After the radial puncture has been successfully completed and a vascular sheath has been placed, a DSA roadmap helps catheter navigation and identification of unusual loops or rare anatomic variants and reduces the risk of vascular injury. Utilization of a long vascular sheath may also reduce issues with vasospasm by bridging the segment of the vessel most prone to developing vasospasm. After successful completion of the procedure via radial access, hemostasis is usually obtained via direct compression of the radial artery to the underlying bones or use of an external compression device. Post-procedural vascular checks are advised for at least 2 hours after completing the procedure to detect any unusual vascular complications. Patients are instructed to limit heavy usage of the affected arm and watch for signs of bleeding, erythema, discharge, or pain at the wrist. In conclusion, transradial access is safe, feasible, and increasingly utilized alternative for vascular access for neurointerventional procedures. Utilizing a smaller vessel at an easily compressible site carries the promise of reduced access site complications. Ultrasonography and DSA roadmap allow good visualization of the vessel and its branches and reduces complication rates. Operators have to be aware of anatomic variants and aberrations that can make the procedure challenging. The decision about transradial or transfemoral access depends on vessel size, vascular and arch anatomy, target vessel location, antithrombotic use, diagnostic versus interventional procedure, and patient preference.